Patient Protection and Affordable Care Act, or the ACA, was signed into law and upheld by the Supreme Court in March of 2010 under President Barack Obama's administration. The ACA contains many reforms to healthcare that aim to expand coverage, reduce costs, and improve the quality of care of all Americans. One aspect of the ACA is the expansion of Medicaid eligibility to include Americans in a wider income bracket, specifically those with annual incomes below 138% of the federal poverty level. This population is disproportionately uninsured and therefore has limited access to healthcare services. The ACA is estimated to increase the number of people with health insurance by 32 million by the year 2019. With an increase in coverage, an impending question is, what happens when a large uninsured population becomes insured? How does the expansion of those covered by Medicaid affect transplant centers and their patient population? More coverage equals more people eligible for transplant. According to the American Journal of Transplantation, transplant centers will be significantly affected by the Medicaid expansion because lack of insurance is currently an exclusion criterion for transplantation. Expansion of the Medicaid program will allow more patients to seek care with coverage, albeit with reimbursement that is inadequate to actually support transplant care. Transplant centers may be forced to accept patients who are guaranteed to result in significant financial losses. Since Medicaid expansion will increase the number of patients with access to transplant care, this will most likely be the primary means of achieving a coverage expansion in the transplant population. However, current data shows that Medicaid patients fare less well with transplants than others. Immunosuppressive drugs are required for long-term transplant success for life of the allograft. Medicaid programs do not guarantee prescription drug coverage. The consequences of not following the strict post-transplant drug regimen are acute rejection, transplant failure, decreased quality of life, and mortality. This leads to increased hospitalization and increased healthcare cost. Even Medicare patients struggle with affording immunosuppressive drugs. Patients covered by Medicare due to end-stage renal disease are only covered until 3 years after the transplant, unless they turn 65 or have a non-kidney-related disability. The three main drugs in the regimen, tacrolimus, mycophenolate, and prednisone, have an annual cost of around $22,000. An estimated 1,300 to 1,500 allografts are lost annually as a consequence of cost-related drug non-adherence. Medicare is the primary payer for renal transplantation because of the end-stage renal disease entitlement, and Medicare is a leading insurer for transplantation of other organs. The expansion of Medicaid under the ACA takes cuts from Medicare. Transplant centers may face significant revenue shortfalls as a result of an expanded number of Medicaid-only patients seeking care. The current Medicaid reimbursement is generally inadequate, often providing insufficient funding to even reimburse centers for the standard acquisition costs to obtain a deceased donor organ. There are some potential positives to the Medicaid expansion in the transplant and pre-transplant population. Under the ACA, these patients will now have access to medical care in a more timely fashion. Expanded coverage for patients with end-stage organ failure holds the possibility to improve early access to transplant services, leading to better care. The individual insurance mandate will enable proper diagnosis and early referral to transplant, and presumably result in better preservation of employment and functional status. In 2012, 26 states sued the federal government, claiming that the Medicaid expansion provision was unconstitutional. The U.S. Supreme Court decided to make state participation in the expansion voluntary, allowing states to opt out of the health reform law's Medicaid expansion. Virginia is one of the states that has yet to expand Medicaid. I spoke with a nurse practitioner on the transplant team at the University of Virginia Medical Center about how the Affordable Care Act has impacted the patient population. She stated, "Since the state of Virginia has yet to expand Medicaid, we have not seen an influx of Medicaid patients. As a Medicare-approved transplant center, we rely heavily on these funds. A cut in Medicare could potentially be a disadvantage. The Affordable Care Act is continuing to change. If Virginia decides to expand Medicaid, it will be interesting to see how this affects our patient population. The transplant process is one that requires a lot of teamwork. Patients need all the support and resources they can get during this period, especially during the first year. The question as to whether increased access will result in improved health outcomes in the face of declining reimbursement remains unanswered. Many states, including Virginia, have not yet chosen to expand Medicaid to non-elderly adults with low income. Transplant centers will need to adapt to this change and develop strategies to manage patients in lower-cost settings. As the Affordable Care Act continues to make its impact on healthcare nationwide, it will be interesting to see what happens when the uninsured become insured.